have advised, right throughout from the beginning is that people should stream their patients. So we should separate out COVID-19 patient or suspect COVID-19 patients from non-COVID-19 patients. So we've been advertising. It's been advertised right from the top. From the ministry level, from the government level, and within the sector. It's been advertised everywhere that people should, if they have these symptoms, they should first call Healthline, and if the Healthline can divert patients with suspect COVID-19 to their practices or to emergency department as needed. So that way we began to triage the patients. So everyone who came into the country, they knew what to do. They had to self-isolate, and if they developed symptoms, they had to call Healthline. And those who were within the country had not traveled, they began to do the same thing as well. If they had problems, they called the Healthline, which is a central Healthline number, and they would triage the patients. Now, I mentioned about bubbles here. So what practices begin to do is that they, those that were able to do. So let's say if a general practice had about 10 people, 10 staff, say 3 doctors, 4 nurses, and admin staff, and what have you. They made a bubbles in themselves. So they made 2 bubbles, bubble A and bubble B. On Monday, bubble A came to work, and Tuesday, bubble B came to work. And that way, they kept those 2 bubbles quite separate. So if somebody got infected in bubble A, that meant that only bubble A stood down, and bubble B could carry on. And same thing they've done in the hospitals as well. They've identified some bubbles. Let's say orthopedic department here, they would have bubbles. If they've got a staff of say 20 people within the hospital, they'll probably have 4 bubbles or 5 bubbles that are taking say weekly turns. When one bubble is not working, they're still doing some sort of paperwork and doing virtual consultations and what have you. So I think that has worked very well. So as you can see that it's been very crucial for us to have that education, have that knowledge about how to actually keep the practices safe for ourselves, but also for our patients. So that has helped build the confidence within the health sector, but also among the public. Business sustainability has been an issue because of the way things are funded, and I'll talk about that in a few minutes. So regionally, what we are doing, and I'm involved in part of that, is I think about 6 weeks ago now, we set up something called community-based assessment centers, and that's through government support and regional district health board support. And basically doctors and nurses, there are some booths that have been set up. There are some are using some buildings, but those who didn't have that capacity within themselves, they've had a separate sort of booth, where they've basically started to swab patients and do a simple assessment where they needed to be done. So we in Auckland region, we've got about 14 of these centers, community-based assessment centers, that have been running for I think now 5 to 6 weeks. So just in Auckland, we've done through these centers, we've done over 26,000 tests in this period. And apart from those, what we call as C banks, we've identified certain practices that have capability to streamline patients and see patients safely, and we call them as designated practices, and that are running as well for the last few weeks. Plus, just over the last couple of weeks, we've been running mobile clinics. So there are some vans that are dedicated to just do COVID-19 work. So we are going out to, aged residential care facilities like rest homes and, those places, and doing swabbing for patients who needs to be done. These are going to houses as well. and to places where it is hard to reach, I guess. So as of just 2 days ago, we have done 108,000, just over 108,000 tests in New Zealand, which for a country that has got what 5 million people, I think it's a good number. So where are we now? We have got 1,456 sort of cases. That is includes confirmed and probable cases. Over 1,000 have already recovered. In hospital, there are about 8 patients. We have had a few deaths just in the last couple of days. There have been a few more. So our numbers have gone up. So currently we stand at 17 deaths. And majority of those deaths actually came from rest homes. And no deaths actually under 60 years. Or half of the cases, interestingly, are the cases that have tested positive are actually in age group 20 to 50 years. So, and I think that's not very different from many other countries. And these are the carriers who actually will not die mostly, unless they've got significant comorbidities. But they are the potential carriers and vectors of transmission actually. So in terms of local transmission, there's only about 4% of local transmission, and there's another 2% still under investigation. We are still working out where those 2% of population have had the infection come from. But rest of the majority of patients who have tested positive have either traveled from overseas or have had contact with someone who's traveled from overseas. So overall, we've managed to flatten the curve, like some of the countries, like say South Korea and Singapore. So which we are really pleased about. So I think the key learnings for us have been, effective and timely government intervention. Our Prime Minister has done a wonderful job intervening at the right time, and we have united together as a country to eliminate COVID-19. And there's been clear communication going out from the sector, to healthcare, but also to the public in general, to get the buy-in, but also to implement change. And that I think has been quite crucial actually. Our public health units have done a great job in contact tracing. Every single a positive case, they've been doing their best to actually do the contact tracing, and that's been very crucial. And once they've identified, they've been able to give them proper advice about self isolation and various other advice that needs to be done. Good case definition and communication of that. What is a case definition? What is a case? And communicating that out to the practitioners, and testing the appropriate population with the available resources that we have. Every country has got constraints, I realize at this stage, but I think we've done the best we can within the resources we have. Financial support has been great from for the sustainability of health services so far. And I think I'm absolutely amazed at the technology adoption by practices, by general practices, and it's been great. How we've switched to pretty much overnight from seeing patients face to face, in-person consultation to just going virtual consultation. And I think we carry we are all in this together spirit. We are working with the regional and national experts on a regular basis and raising concern from grassroots levels. It's not been always easy, but we've been able to raise those issues at a higher level, and those issues have been addressed as they have risen. Now, while I tell all of this, I realize that India and New Zealand are a very two different countries, different demographics, culture, and of course healthcare system. because I've worked in both public and private healthcare system in India, and now in the Western country for the last 18 years. And I do realize that that will have some impact on how we use some of the things that we have utilized here. So primary care is almost half funded by the government here. So the other half comes from the patient. So that obviously would have an impact on how we deliver care. The government obviously has a say in how we do things. And plus, the public healthcare system here is obviously a very high standard. And when people do go into public healthcare, they are really, they get a great care here. Private healthcare system currently under the lockdown, a lot of them are not operating. The ones that are operating are actually doing it virtually. And I think so far we've been okay because I guess we are managing reasonably well within the public healthcare system at the moment. And I think we need to also remember there's clinician and public behavior that are different as well in different countries. So so what might future look like? I think different testing modalities. So serology testing, I know it's already there in many countries. So I think we'll soon begin to do that as well. That will add, I guess, will be complementary to what we are already doing. So mostly we are all the tests are actually swabbing at the moment. So we do nasopharyngeal swabs. I think that's gone very well, but I think we need to complement those things as well as we go along in the next few months or so. Promising treatments, treatment possibilities, obviously under development internationally. And I heard about this CEPC-WAC. All the best with that. Now, until then, I guess, or the vaccine, which might take, good, I don't know, 12 months or more. But until then, I think we need to keep the tsunami away, which is, managing thousands and thousands of cases at one go, and manage just the small ways. So, as we come out of the lockdown, some places, we might see that there is a little bit of outbreak or what we call as clusters here and there. But as long as we can manage small waves, I think we will get there. Who knows about burnout of the virus? But I do believe in miracles, and they do happen. I heard about a 103-year-old lady in the US who survived this, I'm quite happy to take any questions people may have. I know there's some. I think someone had raised about PPE earlier. I think we've had some initial challenges. I think it was more around the fear of the clinicians about adequate PPE, but there's so much of credible information has gone from the top level about what is the best practice in terms of PPE, how to protect yourself safely, and what kind of examination, what kind of PPE is required. All that advice has actually been helpful to allay the fears among the clinicians. And currently, we are, I think, good with the PPE supply. So it's been good. So I think that's where I'll stop, and I'll have some time for Q&As.
Ajay, thank you very much for a fantastic presentation. I think I'll ask you a couple of questions before Amar picks up any questions from the chat box.
Sure.
Shrikant, two things now. We are going to be having the question and answers a little later, if that's all right, Ajay. You can probably get yourself a coffee and then sit there with us and then hang on for some more time.
Okay. Yeah, I'm happy. Yeah.
Because question answers, because Dr. Boogie is already there, and then Dr. Ramchandra is going to be there again, and he's just got up, and so we'll have all the Q&As, because that's the way we can stretch the whole meeting and we can listen to all of you, without rushing you guys up. Thanks, Sri.
How long would that be? It's 11:41 here. I'm happy another maybe
1 hour. Yeah, about an hour.
About an hour, okay. Yeah.
Yeah.
Okay,
Great.
we'll give it a go. Yeah.
Double shot of espresso. That'll do you.
Red Bull, Red Bull.
Red Bull, is it? Ah, you can fly to India now. Fantastic. Now, Dr. Boogie, Ganesh, can you get Dr. Boogie online? I mean, I'm trying to see where is he. And,
If you can unshare your slides.
No, he's already unshared now. He's okay. It's been done. Not to worry. Where are we? Dr. Boogie, we need to get him on somewhere. Ganesh, are you able to track him? Dr. Boogie is here. His video is off. Is it Boogie Avinash?
Well, Dr. Boogie is coming on. Just a quick one. I know a lot of countries are struggling with PPEs, and many of them are importing it from China. What's the story with New Zealand? Have you indigenous production there, or are you still dependent on China with some of the quality issues which has come across in different parts of the world?
Yeah, look, I think we are aware of that, and now what we are as a country, we have there's been quite a lot produced locally as well. I don't think we are producing absolutely everything locally at the moment, but some parts of PPE are being produced here. But I think eventually, in the next few months, I guess it may happen. But I'm not I'm not aware of that sort of thing. But we certainly have got adequate PPE at the moment. Yeah.
Dr. Boogie. Hello, Dr. Boogie. For some reason, he is not able to. Where is he? John, can you? Hello.
Yeah, he's a co-host now.
Yeah. John can start to introduce Dr. Boogie. John, can you hear us? Your Ganesh, can you unmute John?
Done.
And Dr. Boogie also, please.
Dr. Boogie, you can unmute yourself.
Dr. Boogie, you can unmute. Avinash, can you unmute Dr. Boogie, please? Avinash is his son. Hello, Avinash. Oh, sorry.
Hello.
John, you're on. You can put the slideshow.
Yes. Muted. You can talk. Yeah. Hello. Amar.
John, we can hear you. You can go on.
Can I start introducing it?
Yeah. Please do.
Yeah. Hello, Dr. Boogie. Hello, Dr. Boogie. Are you there?
Avinash, can you hear us? Ganesh, can you unmute Boogie, please?
Sir, he need to do it from his end. He is co-host now.
He's not listening. I mean, he's not picking my phone, and I'm not sure where we are with him.
Amar.
We'll get Ramchandra on.
Yeah, better.
Can you introduce Ramchandra?
He's on. Is he on?
Oh gosh, that'd be fun.
ಇವಲ್ಲ ಓಕೆ ಯಾಕೆ ಹಿಂಗೆ ಕಷ್ಟ ಆಗುತ್ತೆ ಇದ್ರ ಮೇಲೆ ತರಬೇಕು ನೀವು ಇಲ್ಲಿದೆ ಅದು
Ramchandra, are you able to come online now? Is it okay? Okay.
Yeah.
Yeah, please. I think we can because we are going to introduce you now. Yeah.
Amar,
Okay. Sure.
shall I go ahead?
Yeah. John, Ramchandra, I just spoke to him. He's coming online now. You can introduce him.
Yeah, is he online right now?
He's from the phone. He's going on to the laptop. You can introduce him now.
Okay. So this is the brief of Dr. Ramchandra Naik, who is an endocrinologist at Washington, Seattle, USA. So know your speaker, know Ramchandra Naik. What is he all about? He's an MD, DM, DNB, endocrinologist at the University of Washington, Seattle, USA. He's currently a clinical professor of medicine in the Division of Metabolism, Endocrinology, and Nutrition. He brings over 3 decades of global institutional experience in patient care, clinical research, and teaching in both academic and private practice settings, drug and device development, and medical affairs in biopharmaceutical industry. Dr. Naik earned his endocrinology certification, DM Endocrinology 1993 and DNB Endocrinology 1993 from the premier institute of our country, All India Institute of Medical Science, New Delhi. Later, he pursued an additional endocrinology fellowship at University of Wales. Then he has held faculty appointments and served as an attending physician at Bombay Hospital in Mumbai, University of Colorado, Denver, University of Pennsylvania, and SUNY Upstate Medical University. He spent 8 years of his career in the pharmaceutical industry, providing clinical and executive leadership in global drug and device development in diabetes. He's my childhood friend and a very dear classmate of mine. We did our middle school and pre-institute together. We have been great friends over decades now. So I'm extremely delighted that he is on board. Over to you, Dr. Ramchandra Naik. We thank you for your participation in the 12th AGOI webinar series. Welcome to you.
Thank you. Can everyone hear me?
Absolutely, Ramchandra.
Okay, great.
Could you hear your introduction?
No, I just logged in. I just saw the picture that you put which you took in during your recent visit, but before that I did not. But that's fine.
Yeah, fine. Amarnath was asking me to go introduce you, though you were not online yet.
Yeah, no, that's okay. Perfectly fine. I think till Dr. Boogie gets ready, I think I can do my part. So that's perfectly fine.
Yeah, fine.
Okay.
Ramchandra, do you want to share the slides or shall I switch it on for you?
Yeah, I will share the slides. Yeah.
Okay, go on then. Go on.
Yeah.
There is a button at the bottom, share slide. Share screen.
Yeah, I'm seeing it's one sec. Got it. Yeah.
Okay. Now you can click on to your PowerPoint presentation of yours today.
Correct.
Yeah. We are able to see that. Yeah, we are going to come now. Yeah, you can go on to your slideshow mode.
Yep. Is it seen now?
Yes, great, wonderful. Get on.
Okay, great. Thank you. So let me minimize the video here. Okay.
You can.
Hi. Once again, good evening, and it's good morning to me. It's 4:50 in Seattle right now, and I'm pretty excited to be here with you all people. And as John said, our association goes long ago, from middle school days in the school through till now. We have kept in touch and been one of the best friend I can say of mine is John Ebenezer. And so when he asked me to speak about the US experience, particularly with a focus on my specialty of diabetes and endocrinology, I thought it's a great opportunity to do so. So I'm currently clinical professor of medicine at the University of Washington, Seattle. I kind of returned here in December of last year. It's been one of my favorite places, and on the right side, you can see here the beautiful downtown view with the Mount Rainier on the backdrop. This is Seattle. This view always fascinated me from 1996 when I first came here to do a fellowship in endocrinology and diabetes. And this is the main, there are 4 campuses, but this is the main University of Washington Medical Center in academic building and or Lake Union. And at the south end of this is our brand new diabetes metabolic research institute, where we have all the basic science, clinical research, as well as patient care activities located in this location, which is my primary workplace. So before I jump into the whole thing, I wanted to provide some insights about what University of Washington has been doing in the COVID pandemic. As all of you probably know, that University of Washington is one of the highly research-based premier medical institute, not only in the country, but around the world. And I feel really privileged to be part of this great organization. And just to give a very quick background, I mean, after my DM endocrinology in 1993 from All India Institute of Medical Sciences, I wanted a postdoctoral fellowship. I reached out to a lot of folks, and I got an opportunity to come to Seattle back then. I did my 2-year fellowship in autoimmune diabetes. And then I returned to Mumbai, where I was already a consultant endocrinologist at Bombay Hospital and Breach Candy. And I continued practicing endocrinology and diabetes in India for till 2007, almost 15 years. Then I returned to the US, and I took somewhat of a convoluted career path of returning and joining as a faculty at University of Colorado, Denver. And subsequently, I moved into a pharmaceutical industry where I spent 8 years with Merck Research Labs and Johnson & Johnson, involved in global drug development in diabetes endocrinology, with primary focus on phase 2, phase 3 drug development, and also in one of the artificial pancreas programs. Then I decided to return to the mainstream academia, and here I am landed in Seattle. So University of Washington, as you know, I mean, Seattle for that matter was the first city, was an epicenter when the whole COVID pandemic began in the United States. And as you know, the nursing home deaths in one of the Seattle suburbs, that was kind of shocking to everyone. From then on, things have changed so rapidly in the field, and University of Washington has kept in pace and has been a pioneer in terms of leading the efforts nationally. And they just rolled out what they call as a COVID-12 prevention and control bundle, which means basically this is what they are implementing across the University of Washington medicine. And that includes the standard processes that you know, from physical distancing, and we doing 100% of our outpatient visits in telemedicine. In fact, we are doing some of the inpatient consults through the video call, especially in the COVID wards. And personal protective equipment, as Ajay was also mentioning, was an issue for a while, but they have gotten over that whole thing. And this was one of the first centers in the country to start a drive-through testing capability for the employees in the first. And this is one of the largest national virology labs, with samples coming from 5 different states here, being a tertiary care medical center. And we have moved through masks not required, through occasional optional use, effective from Monday, this 27th. Masking is mandatory for all staff in the clinical areas, and all clinical staff have gone through training, fit testing, and all the usual stuff that any of the big hospitals generally do. And we just introduced antibody testing, which is an in-house antibody testing that has just rolled out last week, which is basically test the IgG antibodies with a 99% specificity. And that's up and running in our center. And the other development has been with respect to testing all inpatients on admission and pre-procedures. Everybody admitted to any of the 4 University of Washington Medical Center sites go through a COVID testing on admission, irrespective of whether or not they have symptoms. And then US is a country of protocols and procedures and guidelines, and the tons and tons of protocols, emails we receive every day. And this is being just part of the journey here. And the amount of information that has been bombarded in the last several weeks has been just mind-boggling. And in terms of research, it's been always on the forefront. I will come to it in a minute. And so in addition, they also modified a bundle, what is called as a healthcare worker safety toolkit for the people working there. It's pretty much the same as what I just said in general, except that they added support and wellness, childcare facilities and stuff like that. So basically they have been doing what I would consider as a state-of-the-art kind of activities that anybody would kind of consider doing in this kind of a scenario. And I know this whole pandemic has resulted in huge surge of clinical research and basic science research activities together. And what I want to highlight is some of the research initiatives what University of Washington's Institute of Translational Health Sciences is actually involved in. I mean, just to give an example, these are the 8 currently enrolling clinical trials that are going on in the COVID space, starting anywhere from therapeutics to prevention treatment. And the first one is basically, I'm just jotted some notes here, to basically the focus with remdesivir, even though we know that some of the recent studies showed the effectiveness was not there in the China, because whether it was not effective, whether the sample size was less and it was an underpowered study, we just don't know. But ultimately what it boils down to is we need to do controlled randomized studies to bring any therapeutic to the market. And convalescent plasma as a therapy and prevention, some of the biomarker strategies, prophylactic studies, immune profiling studies, and some of the INSPIRE registry. This is primarily focusing on using the remote digital platform to track the patient data, and some of the broader studies of Seattle flu study, etc. So just underscoring the fact that University of Washington has been so much in the forefront, not just in the patient care, in implementing the standard of care guidelines, being the pioneer in terms of implementing the testing and capabilities, and in the research front. And the most important I want to highlight here is the Institute of Health Metric and Evaluation, which is part of the University of Washington. And you must have heard all over the news that all the data projections that are coming out today in terms of the statistical modeling is all coming from the Institute of Health Metrics Evaluation, who kind of, I just put up the snapshots of basically the projections for the United States. And this is a publicly available website wherein you can go and actually look for individual state data, and some of the other countries are represented as well here. That shows, like it shows that this was, I just downloaded yesterday, 9 days since the peak that is over in the entire United States. It also looks at the resource utilization, how many beds are needed, how many intensive care ventilator capacity, and what's shortage. And this varies from state to state. And these were the death projection that have been talked over almost every other day, at least by CNN, wherein they said initial projections based upon the data at that point and modeling was around 85,000, which came down to 60. Now current estimate is 67. This shows the area of uncertainty, but this could go up and down depending on how the social distancing measures and how the country is reopening. That's been a big chapter. I won't get into the politics of that here. This is where we stand today in the US, unfortunately. This is a grim picture. You can see here, as of yesterday night, 11 o'clock this morning, India time, it's been 928,000 cases with almost 52,000 deaths. That's a sad state. And this shows the new case and the cumulative cases and the new cases on the green line here. And this shows the distribution. Seattle is here in Washington, and New York and New Jersey currently have become the epicenter. And all these somewhat orangish kind of a thing, dark orange, are all between 10 to 50,000 patients. And Washington State has, I think, as of yesterday, were 13,000 patients with some 700 deaths. But one good point is the Washingtons, and along with California, I would say, have contained significantly well. And currently, Washington, which was number one, it was an epicenter when the pandemic began, as of now has moved down to number 16 in the list of 50 US states, which is a good sign. And we are hoping to get back to the full routine, even though it will be a new normal. It's may not be exactly the same, but I think whatever one could accomplish. What is also important to note here is from where this 900,000 cases came. I mean, again, all over the US, I mean, there has been big hue and cry about lack of testing availability, whether it is RT-PCR, whether it's now antibodies, and the pros and cons of antibody testing, false positive, false negative. FDA approved to use without much of guidelines, but now they are coming hard on it. But anyway, but the fact remains that I think the number of testing done has been quite remarkable, and total number of testing done in the US as of now is 4.9 million, 49 lakhs testings done to identify 899,000 positive patients with some pending data. And the positive rate is 18.2%, and the case fatality has been varying from as low as 3% in some places to as high as 10% in New York City. That is a bit sad. So this is the grim picture. Hope we get better. And US obviously did not do as well as many other countries, including India, in terms of containing efforts. But the positive, what came out of all these things? What came out of all these things is the huge amount of research and data mining. And the amount of research publications that have come out of in the last few days has been just phenomenal. When I read articles published in the month of March or even April first week, it sounds I'm reading the article published 2 years ago. I mean, it's the pace at which the things are moving is just unbelievable. It is, I would compare it, I read it somewhere in one of the magazines or journals where it said that trying to catch up with the data up to date is something like chasing aircraft which is taking off on a runway with a bicycle. It's exactly the same scenario here. So with this, what I want to now quickly spend in the next 10, 12 minutes was about, in my specialty related, diabetes and endocrine diseases, how we manage in this current scenario. That brings to the first question as to who are at high risk for severe COVID-related illnesses. I mean, this is well known. We have discussed it from the time an outbreak happened in Wuhan, China. It's been debated. There is, I don't want to go too much into the detail, but suffice it to just recap, going directly from the CDC guidelines, that patients who are 65 and plus, that really applies to geriatric population, which you all deal with under the geriatric orthopedic society. And people, obviously, this has been a big issue in nursing home and long-term care facilities. The number of deaths and morbidity that we have seen in not just Seattle, New York, everywhere. Here, I'm talking from a US perspective, nursing home and long-term facilities are very badly hit. Underlying medical conditions, you all know, lung conditions, heart condition, immunocompromised, steroid therapy, organ transplant, immunodeficiencies. I mean, we've been actually quite concerned about our transplant patient. We have a major organ transplant center. I think in the last 2 months, I must have seen about at least 6 to 10 patients who had undergone heart transplant, another half a dozen with lung or kidney transplant or multiple organ transplant, hematopoietic stem cell transplant. So these patients all get immunosuppressant and steroids, and then they come with diabetes. And then it was a big challenge for us. These people are coming to the clinic for their appointments to manage their diabetes, and they're moving around in a city which was flooded with COVID patients. So transferring all their care to basically a virtual telemedicine visit and managing their diabetes with in a remote way has been a big challenge actually in our practice. Severe obesity, BMI of 40 or more, people with diabetes, chronic kidney disease and liver disease. These are just the list as is put together in a CDC's website. Now, going to the diabetes part, I just want to make one point here. We don't know really whether diabetes increases the risk of getting COVID infection. We don't know if, I mean, if you ask a question, if there is an uncontrolled, I mean, if it is a well-controlled type 1 diabetes on insulin pump, 25-year-old or say 35-year-old is his or her risk of getting COVID is higher than a general population? I personally think not really, but we don't have an answer and very clear data. But what we know today is diabetes is an important risk factor for severe illness, morbidity, and mortality. So if the diabetes patient were to get a COVID infection, the severity of the illness and the mortality is significantly higher. That has been established with multiple studies. And the major contributors are hyperglycemia and diabetic ketoacidosis. They contribute to the morbidity and mortality, including people who did not have diabetes. And we know that in an acute stressful situation, inpatient hyperglycemia is a very well-known and well-established thing. So if people who were pre-diabetic or who were on genetically predisposed, they get admitted with COVID infection, and then they get into hyperglycemia, that puts them at high risk of developing complications related to the COVID. So I want to quote a couple studies here. One just came out from Bruce Boogie and another 50 plus US investigators. It is all these publications which are put in the parenthesis here with only year, without the actual referral, without the actual citation, means these are preprint online available publications. They are yet to be published in the journals. What they did was they evaluated the glycemic and clinical outcome in patients with and without diabetes and or acute uncontrolled hyperglycemia in hospitalized patients between March 1st and April 6th. This is a 5-week data. Total of 1,122 COVID patients in 88 US hospitals were studied, and 451 of them had diabetes and hyperglycemia. And COVID patients with diabetes and or uncontrolled hyperglycemia, this study showed that the duration of hospital stay, length of stay, was statistically significantly higher. The mortality among patients with diabetes and uncontrolled hyperglycemia was 28.8% versus 6.2% of these 1,121 people who had COVID. This was highly significant. And patient with uncontrolled hyperglycemia had a particularly higher mortality of, so basically they're looking at 3 things here. Length of stay in the hospital was higher in diabetes. People with diabetes has a higher mortality, but if they're poorly controlled, their mortality was 41.7% versus 14% in people who were well controlled. So this was a clear data that just is emerging, indicating and again underscoring the association of diabetes with high morbidity and mortality in COVID. And again, an early study from Wuhan, China had shown that fasting blood glucose independently predicted multi-organ damage, poor outcomes, and death among COVID patients. Now, we all know that diabetes primarily is type 1 diabetes occurring in children, autoimmune pathophysiology, require insulin from day 1. Type 2 diabetes, family history, genetic factors, no autoimmunity, combination of insulin deficiency and insulin resistance occurs in the adults and elderly population. There is also an entity called type 1.5 diabetes, latent autoimmune diabetes in adults, which is an autoimmune diabetes phenotypically presenting as type 2. And then there is another diabetes, which is described in certain regions of New York called ketosis-prone diabetes. This is not falling into the typical international classification of diabetes, but these people phenotypically are ketosis, are type 2 diabetes. They are obese, they have strong family history of diabetes. But type 2, by and large, we know that they should not get ketoacidosis unless there is a huge stress. But these group of people in Bronx area of New York, they found that the proportion of people with type 2 diabetes were extremely ketosis prone. This was a new finding and it was known in that region, but suddenly they saw a huge surge. This was some of the patterns of presentation of diabetes that was changing in the middle of the COVID pandemic. And again, we see either pure ketoacidosis in type 1, or you see what is called hyperosmolar non-ketotic diabetic state, which is primarily in type 2, and a mixed picture. Atypical presentations are seen more often in COVID patients. Again, these are not from any published studies. Again, these are data from what we see in the clinical practice and from the expert opinion. So that's the reason I have not quoted any references for these things. One other thing to note, I have seen at least 2 patients in the last week in an inpatient consult service, extreme levels of insulin resistance. the amount of insulin these patients are requiring is phenomenally high. Just last week, I got a call from my fellow in an admitted patient with COVID, with the florid multi-organ failure, with ARDS and acute renal shutdown, and is being severe cytokine storm. Blood sugars were 500. This was a patient with mild diabetes, well controlled previously. We were giving 50 units of insulin, regular insulin every hour. 4 hours, the sugar would not budge. We don't know, there is nothing else we can give other than insulin. We kept pumping insulin over hours, but eventually the patient succumbed, unfortunately. But this just shows the amount of insulin resistance in this middle of this highly inflammatory cytokine storm related condition can be a big challenge in managing diabetes here. Now, the monitoring part is more US centric kind of a thing. In India, I was practicing in Bombay Hospital for 15 years. I mean, we used whatever meter that was available to check the blood sugars in the inpatient floors. But US hospitals use a hospital grade glucose meters to test the blood sugars in a hospitalized patients. Patients are not allowed to bring their glucose meter to check it. And the continuous glucose monitoring data, that's where the whole diabetes management is heading today. I mean, we have more than 50% of patients type 1s are on pumps, and 70% of the patient in the clinic population in the tertiary care center are on continuous glucose monitoring, wherein we have a sensor which transmits the data by radio frequency signals to a receiver, and that can be paired with cell phone. I think India also has Dexcom, and Abbott Freestyle Libre had made a big inroad in India, actually. And these continuous glucose monitoring devices currently in the US are not approved for the inpatient use. They are used only for an outpatient ambulatory setting. But US FDA quickly gave approval to 2 devices, the Dexcom G6, which is almost like a gold standard in CGM, and Abbott Freestyle Libre, which is much more user-friendly, easy to use, but may not have the same sensor accuracy as Dexcom. But these are being used in the hospital. So why do we need to do this? Patients can bring their meters, check it. So you are reducing the exposure of nursing staff and on the floor nurses to go into the patient's room and check the sugars by the hospital devices. So this is a major one, to reduce the exposure to the staff. And number 2, it is basically also to conserve the PPEs when you are dealing with the COVID patients in the inpatient setting. So now these are some of the nuances which may be very more relevant in the US, but not so much in India. But I just thought I will share what's going on here and share those perspectives. Now, what happens in an outpatient setting? If a patient of diabetes, you suspect COVID in a clinic, what do? We tell them, okay, rush to the hospital, but we tell them, again, it is more of a US nuance. They need to carry their glucose meter, test strips, and CGM, because all hospital formularies may not really have the insulin preparation they are taking. So we don't want to make any switches. You don't want to switch somebody taking a glargine insulin to a Tresiba insulin and back and forth. So the bottom line, try to keep the thing simple. If the patient is not severely sick, is not heading for a ventilator kind of a support, try to manage with whatever insulin regimen the patient is already doing, especially type 1s. Never stop basal insulin, because that puts them at a very high risk of diabetic ketoacidosis. So, but if the patient goes on to ventilators or some of the other serious complication, obviously the management is IV insulin infusions. But otherwise, we try to manage with a subcutaneous insulin in an inpatient setting and try to follow what the patient was already doing, except for the fact that we stop all the oral hypoglycemic agents. The problem is the patients in the hospital can be going for some CT contrast studies. Their renal functions can vary, and drugs like metformin will pose a big challenge here. And one of the drugs which has been a bit tricky here, I don't know, you might have heard about the drug called SGLT2 inhibitors. These are sodium glucose co-transporters at the kidney. They lead to increased excretion of glucose from the kidneys. So the way the blood glucose levels come down by this SGLT2 in the blood is by inducing glycosuria. When they lose glucose, they lose calories, water is lost, so their fluid retention and some degree of weight goes down, and then their blood pressure improves. So they have proven to have beneficial effect upon not only the blood glucose control, but also on the hypertension, body weight, and of course, there is an increased risk of urinary tract infection. There were reports that people are at high risk of euglycemic ketoacidosis, and the risk of amputation was higher. But again, it needs to be individualized. Most importantly, this class of drugs, canagliflozin and empagliflozin and dapagliflozin, have shown to have a beneficial effect in terms of the cardiovascular and kidney outcome. These drugs are being used nowadays by cardiologists to treat heart failure because the beneficial effect on the cardiovascular morbidity and large cardiovascular outcome trials have shown that these drugs are extremely beneficial in terms of reducing the risk of heart failure, and also by people with established atherosclerotic cardiovascular disease. So we use diabetes patients with an established heart disease. We use two classes of drugs. One is either an SGLT2 inhibitor or an GLP-1 receptor agonist, like Victoza, liraglutide or dulaglutide, etc. So, but in COVID patients with a risk of ketoacidosis being high, again, we don't have data to show that SGLT2 will precipitate ketoacidosis in a COVID diabetes patient, but as a safety precaution, the general recommendation by amongst the diabetes community, including the American Diabetes Association, has been, okay, just put them off of SGLT2 inhibitor and just use only insulin. Similarly, there is a trial that is going on to look at DPP4 inhibitors like sitagliptin, linagliptin, etc. But again, the degree of insulin resistance is so huge, none of these tablets are really going to work. I think the simple, straightforward answer, if you have a COVID patient with diabetes in a hospital, manage with insulin, stop all the oral drugs. And you can do subcutaneous as long as the patient can take orally and is otherwise stable. But if the patient gets serious, then you need to get on to intravenous infusion. So every patient, the current guidelines that we implement in our hospital, like everywhere else, is blood glucose should be tested for every patient admitted for COVID. Ketones should be checked. If ketones are high, look for pH and bicarbonate. Most of the US hospitals, they do the chemistry panel, renal and liver panel that generally gets the blood glucose. But many a times it can happen that if person is not a known diabetic, when you scan through tons and tons of lab results, you may just miss a elevated blood glucose level accidentally because the patient is not a diabetic and you don't anticipate the blood sugar to be high. But so one need to be careful in looking at the blood glucose value here. And if the patient has a random blood glucose of 180 to 230, that anything more than 180, do the A1C. Maybe they had diabetes, which was missed at the time of diagnosis. And again, another confounding factor we see is patients' complaints of shortness of breath because of COVID, but and they have got ketoacidosis. We don't know whether the shortness of breath is because of diabetic ketoacidosis or is it because of the respiratory complication of COVID. This poses again significant challenges in the management of the patients. And as I said, never stop basal insulin in type 1 diabetes. And with FDA's loosening guidelines of using continuous glucose monitoring, that has made a big difference in reducing the exposure to the nursing staff. And I talked already about subcutaneous and IV infusion for those who are sick, critically intubated, tube fed, acute kidney injury, high dose of steroid, etc. Now, fluid management is again critical. COVID patients tend to have, they have a cardiac decompensation, they have congestive heart failure, and they have ketoacidosis. In ketoacidosis, we pump fluids, 3 to 6 liters of starting with normal saline followed by glucose insulin infusion is a standard of care in ketoacidosis everywhere in the world. And now what do? Do you pump them with a lot of fluids because they have got ketoacidosis, or they are in circulatory compromise and with ARDS and cardiac decompensation, should we restrict the fluids? That becomes again a big challenge. And the current data understanding, we don't have any studies to support this or refute this. The general understanding is ketoacidosis takes the priority because the probability of a person dying of uncontrolled ketoacidosis and dehydration is far higher than living with some degree of fluid overload until the ketoacidosis comes under control in 1 or 2 days, then you switch back to whatever the COVID regimen is. Now, so this is just a very high level what we do in an outpatient setting with diabetes. I'm not talking about telemedicine consults, and but how do you manage in an inpatient setting, and what kind of presentation challenges phenotypically, what kind of management challenges one can see in a diabetes patient with COVID? I think that's what I wanted to mention. Next question, does COVID lead to any injury to the pancreas? We don't have a clear answer. The study was just published. This was done in Wuhan University Hospital between January 20th to February 28th. 52 patients with COVID pneumonia, 17% had mild pancreatic injury. They defined pancreatic injury as any abnormality of lipase and amylase. So compared to patients without pancreatic injury, those with pancreatic injury, by which I mean who had demonstrated abnormalities in the lipase and amylase levels, they had a higher incidence of anorexia, diarrhea, severe illness, lower levels of cytotoxic T cells, higher levels of liver enzymes, creatinine, LDH, and DSR. So that brought a question, how COVID-19 damages the pancreas. So there are two hypotheses here. One, it could be a direct viral involvement of the pancreas, and because similar phenomena was described in 2003 SARS outbreak, pancreatic damage directly by the virus that has been reported. So one can postulate if that could be a mechanism. Alternatively, the enzyme abnormalities could be secondary to severe illness without substantial pancreatic injury. Cytokine storm could be inflammatory state cause damaging the pancreas. So it could be both, and that is leading to elevation of enzyme. We don't have a clear answer. What we know is data from the patients who have already had COVID, either in China or US or anywhere, the pancreatic injury tends to be mild. It is not severe pancreatitis, and like an acute florid necrotizing pancreatitis. We have never seen that. At the same time, as I said, the data is too preliminary and we need further research, and large series are warranted to evaluate these subset of patients with pancreatic injury and try to, evaluate them more carefully in the future. I spent little more time than what I thought I should have on the SGLT2 inhibitor, sodium glucose cotransporter inhibitor in management of diabetes. I said 2 minutes ago that SGLT2 inhibitors have produced a higher risk of euglycemic, normal blood glucose, but ketoacidosis, so we should conservatively stop the drug. Here we come. Bristol Myers Squibb, I think dapagliflozin is a drug, and it is one of the SGLT2 inhibitor. They have just launched a study of COVID-19 patients of cardiovascular, metabolic, and renal risk factor. This is called dapagliflozin in respiratory failure in patients with COVID-19, DARE-19 study. So what, this sounds counterintuitive. This is contradicting what I just said, but that is what it is. When we don't have much information, people are trying everything, and everyone try to seek the best possible treatment option for these patients. So what this study is doing is, that's an international study, including US and other countries, multi-center, parallel group, randomized, double-blind, placebo-controlled study. 900 patients are expected to be enrolled in a hospitalized mild to moderate COVID patient not on ventilator. The objective is to see if dapagliflozin 10 milligram versus placebo given once a day for 30 days, in addition to whatever standard of care in that particular local hospital is going on, is it effective in leading to reduced disease progression of COVID? Does it reduce the complications and all-cause mortality here? So the primary endpoint, efficacy endpoint, is to time to the first event of all-cause death in those 30-day period, or morbid disease complication, like somebody admitted with moderate COVID, put them on randomized into DEPA or placebo, and at the end of 30 days, you see how many of them actually died and how many developed respiratory, cardiovascular, kidney complication, and see whether there is a difference in these two groups. The underlying premise or hypothesis here is, we know that patient with cardiometabolic disease, be it diabetes, hypertension, atherosclerotic cardiovascular disease, or heart failure, and people with CV complications are known to have markers like N-terminal pro-beta natriuretic peptide. This is basically a hormone produced from the heart in response to a fluid overload. And this reflects the state. It's like a biomarker for congestive heart failure and acute myocardial injury, acute kidney injury. These are known in patients with cardiometabolic disease. And as I mentioned earlier, that SGLT2 class of drugs have been shown to reduce the cardiovascular morbidity and mortality in the outcome trials, and the renal benefits have also been established. So now, if they have got all these benefits in a COVID kind of a situation, the underlying mechanistic process of dysregulated mechanistic processes that are dysregulated in COVID, including inflammation, cytokine storm, can they be positively impacted in terms of reducing the morbidity and mortality? That's what they're looking at using the dapagliflozin. I think it is approved by US FDA. This is already on the clinicaltrial.gov. The trial is up and running. Hopefully, in next couple of months, we should have some answer whether or not SGLT2 inhibitors, which is a diabetes drug, can be used in COVID, not just to treat blood glucose, but to reduce cardiovascular morbidity and mortality. Another point from endocrine standpoint is obesity is the biggest risk factor. I told you in the CDC list, BMI of more than 40 is a major risk factor here. So one study that just came out, again, it's I think it's still a preprint material. It's a preprint version from the New York hospitals. It was a cross-sectional analysis of identifying the risk for adverse outcome in a lab-confirmed COVID patients. It was in an academic health system of New York City, done between March 1st and April 2nd, with a follow-up through April 7th. The outcome was hospitalization and critical illness. How many patients had intensive care, mechanical ventilation, hospice? Hospice, for those who don't know, it is basically a palliative care for terminally ill patients, wherein they are given emotional, psychological, spiritual support and pain relief kind of a thing. So that means their longevity, expected lifespan is very limited. They are sent to a comfortable environment. So how many people went into intensive care or mechanical ventilation or died or went to the hospice care? That was the outcome of this assessment. 4,000 COVID patients were looked at, and out of which 48.7% were hospitalized, of which 14% died, were discharged to hospice care, and 455 required mechanical ventilation and 36% died. This was an outcome. So now they try to look in a cross-sectional way, what actually determined the outcomes here. The strongest predictor, again from the geriatric point of view, age of 75 years, was the strongest risk factor for any of these events that I just, critical illness and morbidity and mortality events. The odds ratio was 66.8 with confidence interval, you can see 44 to 100. So people who are 75, in other words, are greater, are at 66 to 67 times higher risk of dying or having ending up with any of these complications if they get COVID. That's an unfortunate fact. Age of 65 to 70, the association was still strong, 10 times greater fold risk of getting these complications. And the third one, after 75, age 65 to 75, the third factor that came up was a BMI of 40. People with morbidly obese, 40 BMI, have 6 times higher risk, and heart failure was the fourth one. And there are a whole bunch of other endpoints. I'm not going into that, but the whole purpose of this slide was to highlight this study to show, in addition to again underscoring the fact that how elderly age is one of the major driver in terms of determining the complications in the hospitalization in hospitalized patients, and also in terms of driving the mortality. But the limiting factor is these patients, because the New York data is, 250,000 patients, significant deaths. The demography of New York is different from Wuhan, it's different from Italy, different from Seattle. So I don't know yet, and we don't know yet, if the data from New York City is one